Josh, for the kind introduction, and a big thanks to the Zero Project for including the issues about psychosocial disability in this fantastic conference about disabilities. I represent an organization called MHAT, Mental Health Action Trust. And what I'll do is to, as others have done, to take you through a short introduction, describe the model, the impact it has had, and what we see as the current challenges and what might be the challenges for the future. I also would like your opinion later on whether you think this model is applicable in different settings other than ours. So the background of our work is that it is set in Kerala, which is the small, tiny, long piece of land on the southwest corner of India. Peter and others have mentioned about the global situation about mental health issues. In India, everything is magnified because we, in terms of population, we are in a separate league of our own. So all the problems are multiplied. But whatever Peter and others have said stands good for us. And globally, we must not forget that for the last 20 years, we have known that in terms of the global burden of disease, neuropsychiatric conditions are in the first, occupy six of the first 10 places. So in terms of burden of disease, in terms of morbidity, in terms of the cost to society, neuropsychiatric conditions are in the six of the top 10. Depression itself is the number 2. So multiply all that by the magnitude of the problems. In Kerala, we are one of the small states, but we are highly densely populated. We have about close to 900 people per square kilometer. Our population is about the size of Ghana and probably a third of the population of Vietnam. I think the whole population of Bhutan will occupy just the city that I live in. So our problems are huge. And needless to say, there is a huge mismatch of need and the resources available. The other problem with our mental health care system is that there is huge social inequities because most of the available resources are concentrated in cities, and we have most of the resources in the private sector, so that people have to pay out of pocket, not insurance funded, but out of pocket expenses. Apart from that, most of the care is confined to prescription of medicines, and that biomedical model, as we all know, is what has given psychiatry a bad name, and it is grossly inadequate. We do know that that alone doesn't suffice. We need psychosocial care, psychosocial interventions, support for families, groups, group therapies, and above and all, community-based rehabilitation. In the background of this is my own personal story. I was working in the UK for about 15 years in the NHS. And then about 10 years ago, I went back to start this initiative. And part of that is because of the success of the various Kerala models or Kerala paradoxes that some of you may have heard about, which is that for a low-income country, we have high social indicators. It's more nuanced than that, but basically that is it. And we have had a long history of people's involvement in various aspects of our life, in the literacy movement, and now of late in the health movement as well. So that was the inspiration, and the aim of MHAT was to develop a set of services for the rural, mostly rural and semi-rural poor people, entirely free at the point of delivery, and involving local partners. So we needed to innovate. So that is how we started our journey 10 years ago. And central to understanding our model is the concept that it is completely decentralized. We have 55 centers built up over the last 10 years across 8 districts of the small state of Kerala. And these are local partners, most of whom have approached us after hearing about our work, and they are equal and autonomous. We set the quality standards, we set many of the guidelines on what care should be provided, but within that, they have a lot of individual freedom and autonomy. We do not franchise the MHAT model. We prefer to be behind the scenes. And that is because it will be sustainable in the long run only if ownership is there by the local groups. And central to our modus operandi is task sharing, already mentioned. Essentially, we make use of the few professional people that we have by training others, non-professional mental health workers, in the delivery of mental health care. And as I said, it is comprehensive, not just in the traditional psychological services, but also in that we provide the service within the context of social development. There can be no mental health programs standing in isolation. If people are starving, then nothing else is more important than that. So we empower communities, we encourage them to look after the mentally ill in their own settings. Nobody is hospitalized, it is entirely community and home-based. And we leverage technology in a big way. The only psychiatrist, as somebody mentioned in the morning, the downside of Zero Project is that the only psychiatrist in MHAT is away in Vienna, but we are managing very well because of the use of technology. Because of the time difference, I am able to get up in the morning, supervise all the work which is happening there over WhatsApp and Skype, and we have an electronic database which generates prescriptions, so I can continue to supervise my work wherever in the world I am, provided there are good telecommunication facilities. All this leads to the fact that stigma gets hugely reduced. All these centers are not labeled as psychiatric centers, but as community centers, and the people who are looking after people with mental disabilities are members of the same community. So over time, we find that stigma is hugely reduced. So, so in terms of our reach, we look after at any point in time around 4,500 people. And that is across the 8 districts and 55 centers. What are our current challenges? Mainly with the mindset, we receive very little support from professional groups. This model is still not looked upon as the right model. In a society where the doctor, everything is doctor-centric, it is a big challenge to convince people that task-sharing models can work equally well. And my plea to the international community is to help us with evaluating our project and also with providing evidence of such task-sharing models. We need to convince the powers be that this is the model that will work. We thought we were getting somewhere by replacing the power structures within psychiatry by moving care from the institutions to the community, but we find that we come up against new power structures in the local teams that we work with. So it's a long process of convincing people about this, and of course financial limitations are there. We are a non-profit organization dependent on donations, and the financial constraints are huge. So what do we see for the future? If we go on at this rate, the gap that my colleagues have spoken about will continue to widen. Mental health care, unless it reaches to large sections of the population, will undermine whatever other successes that as humanity we have made. And for this, we need to leverage technology. We are at the right point in history where that is possible, and we need to innovate. We need to bring in ideas. We need to make mental health care the business of everybody, not just the professionals. And we are all in it together. We play roles as patients or carers or as caregivers, but those are all different roles that we play. All of us should get involved in order that we can make a difference to this traditionally neglected group of people with severe disabilities. Thank you all for a patient hearing.
Thank you, Manoj. I'm delighted to say that our kind timekeeper has told us we have a little extra time,